Let us discuss about the management of OCD. So, as you are well aware, OCD is a chronic illness which tends to wax and wane. The symptoms may go up and they may go down. The patient may improve and then there may be re-emergence of symptoms, right? It tends to wax and wane. We learnt about the concept of DUP, duration of untreated psychosis, while we were discussing schizophrenia. Similarly, there is this concept that from the onset of symptom, how much time does it take for the patient to seek treatment? Now, research from the Western countries tell us that it's almost 10 years in adults and it's almost 2 to 3 years in children. This is the data from Western world. So, we can presume that in our country, in developing world, the duration may be even higher. Now, it has a direct implication on the management because the longer duration of untreated OCD is correlated with poorer treatment response. Now, this becomes an important aspect while you are psychoeducating the patient. Many times what will happen is your patient will come to your clinic, your OPD or your hospital, and they are actually pushed by or nudged by one of their relatives or family members, and they are not there to start treatment. Sometimes they are just there to see how it goes and what does the doctor say. Often they are not even sure whether they have an illness or not. So it's important that while you are telling about other stuff, while you are telling about the illness, while you are telling about the treatment options, you should also tell that if there is a lot of duration between the onset of symptom and seeking of treatment, it may lead to poorer treatment response. Not only the treatment response, the risk for the general medical conditions also goes up. Now, when we will discuss the different recommendations, we will be making reference to what APA has said. So, APA guidelines for OCD, they were released I think in 2007, and then there was a watch release somewhere around 2013. But whatever they said still kind of holds true. Most of it is still in sync with the current guidelines, and APA being APA is a more trustworthy source. So, we would be citing something from APA, certain things from APA. So, APA has got divided the recommendations into 3 categories. Category 1, where we have a substantial clinical confidence. Then we have category 2 with moderate clinical confidence, and then category 3 where individual circumstances. In individual circumstances, we may use whatever was recommended, but it's not a general recommendation. When we discuss about the management, first of all, we have to talk in terms of locus, focus, and modus. Locus is where do you want to treat your patient. Most of the patients with OCD would be treated in the outpatient, on an outpatient basis, right? Very rarely you have to admit the patient. For example, if patient has high suicide risk, or patient has very severe OCD, or you are not sure about the diagnosis, you want to do diagnostic clarification, or the patient is very prone to adverse effect, there are certain comorbidities, medical comorbidities. In those cases, you may consider inpatient admission, but otherwise, as a rule, you want to treat your patient in the least restrictive setting possible. Focus of treatment cannot be only symptom improvement. You have to ensure that along with improvement in symptoms, there is improvement as far as functioning is concerned. You want to get the patient back into the productive work. In the productive world, you want the patient to be functional and productive. And of course, quality of life should be good. And modus is how do you treat the patient? So, grossly speaking, we have got medications, we have got psychotherapy, we have the option of combining the two. And in certain severe and intractable cases, you have other options like psychosurgery, DBS, RTMS has been approved now. So, we'll talk about all of that in a short while. Initial treatment modality. So, this recommendation is very clear cut across the guidelines. Cognitive behavioral therapy, primarily using the behavioral techniques like ERP, exposure and response prevention, and SRIs, serotonin reuptake inhibitors. They are the first line treatment for OCD. APA recommends this clearly as a category 1 recommendation. Now, when you talk about SRIs, we talk about SSRIs, of course, and we also talk about the clomipramine, which is a TCA, serotonergic TCA. Now, whether you go for CBT, whether you go for SRIs, or whether you go for a combination depends on multiple factors. So, for example, the severity of illness. If the OCD is severe, In that case, probably you would not want to start with the therapy alone, because if the symptoms are severe, patient may not be able to engage in the therapy. So severity of the illness, sometimes the nature of the illness, sometimes the symptoms. There are certain symptoms which do not respond well to medication or therapy. Comorbidities. If there are comorbidities which respond well to medications like SSRIs, you prefer using medications. For example, if a patient has OCD with major depressive disorder or with GAD, and you know that your SSRIs would work well in these conditions, you would want to include medications here. Availability. Now, CBT may be very effective, but it's not available always. And CBT is more comprehensive. It takes much more, money. It is just more costly to get this treatment. And the number of experts who can give good CBT treatment are always limited. So availability is also a very important parameter. Past response. If somebody has responded very well to CBT in the past, probably you want to go with CBT only. If somebody has responded very well to medications in the past, you want to go with the medications. So CBT alone is recommended as initial treatment if the patient is not too depressed or anxious and not severely ill, right? What we just discussed, if the symptoms are severe, probably you do not want to start with the CBT, you want to start with the medications at least. And similarly, if there are comorbidities, you want to add medication or start with medications. But if the patient does not want medicine, and this might be a big number, there are a good number of patients who would say that, doctor, I do not want medications, I want to start with therapy session. In those cases, you have to respect the will of the patient, start with CBT. And see, practically also it works. Say you are a psychiatrist, a patient comes to you, patient says, doctor, I don't want medicines, I have heard there are a lot of side effects, once you start medications, you can never stop them. After telling the facts, the scientific facts that answer the patient's question, if the patient still wants to continue with the therapy or start with the therapy, you should not push the patient too much towards the medication. Why? You start the patient on CBT. If the patient improves, great. If the patient does not improve, now the patient knows that this particular modality is not working for me and the other viable option is medicine. So in both cases, it works well for the patient. Either they become better or they become clearer in their head what should be the next treatment that they should take. Patients often do not understand what therapy means. They think that it's just a counseling kind of thing where they'll go and somebody will tell them something and they'll become better. That is not what happens in reality. Patient has to work. Whatever is taught or whatever is explained in the CBT session, often homeworks are given. In almost all cases, homeworks are given and patient is supposed to go back home and practice those techniques. It takes a significant amount of effort on the part of the patient to engage in that CBT. In that treatment modality. So patient must be willing to work along with the therapist. That is also a prerequisite to start CBT on a patient.